Hello, everybody. My name is Robert Riley, interventional cardiologist at the Christ Hospital in Cincinnati, Ohio. And today we're going to be talking about a few tips and tricks for I can get my wire across the lesion, but I can't get anything to follow it. And this is definitely applicable to CTO PCI, but it's certainly applicable also to non-CTO PCI, these really heavily calcified lesions where you just can't get anything to cross. These are my disclosures. So the case presentation is regarding a 60-year-old male who is referred to me regarding a second opinion for complex CAD management, history of hypertension, dyslipidemia, and CABG surgery in 2010, with an SVG to RCA and a lima to LAD. Recently told his cardiologist at another group he developed class 3 angina and NYHA class 3 dyspneic exertion, put him on optimal medical therapy. Unfortunately, didn't really make a dent in many of his symptoms, pretty lifestyle limiting at that point. Echo showed an EF of 40%, so mild dysfunction with no significant valvular disease, got sent for a nuke. Showed high-risk inducible ischemia in the inferior distribution. So this then obviously led to subsequent diagnostic coronary angiography, which showed this degenerating vein graft to the RCA in the setting of a dominant RCA CTO, and was then referred to my center as there was going to be a lot of metal put into that vein graft, and we all know what happens to vein grafts with a lot of metal in them. So at this point, we had some outside angiography, but here's a few setup films. You'll see that I've got bifemoral. In this case, the patient's left radial had already been used, and we knew that there was going to be heavily calcified disease. So bifemoral 8 French guides. You can see we've got a wire down the SVG as a sort of just to hold the guide in place, and then we've got an antegrade wire and microcatheter set up there. You can see it's relatively short CTO there. It has a bifurcation there, and we can see that it's relatively heavily calcified there. So in this case, you can see a contralateral view here. Again, very short segment. There is a reentry zone right before the bifurcation, so we decided to start with integrated wire escalation, and it turns out we've got a 135 microcatheter and a workhorse to the proximal cap, pilot 200, as you can see on the right, polymer jacketed wire, tapered wire is able to go across the proximal and distal caps into the true lumen. You can see the wire moving side to side there in the true lumen just past the distal cap on the right side there. So we think, man, we're home free, quick case, easy peasy. Unfortunately, the microcatheter would not go. And there's an algorithm for how to deal with that. You can see on the bottom here that's published in our algorithms within the algorithm manuscript from a few years ago in CCI for CTOs. Now, the first thing is to increase guide support. You can see on the left side there, I've got a big 8 French guide extension in there, and I am pushing with all my might with a small balloon, as evidenced by the AL prolapsing into the aortic root, because again, how hard we're pushing with small balloons. We couldn't get a small balloon to go through, so we purposefully rupture it to try and frack the lesion, go back in with microcatheter small balloon, still won't go. Then we tried different types of microcatheters, so smaller, lower profile microcatheters, harder microcatheters with gold, like a gold turnpike gold with threading on it, like a turnpike spiral, like an old school tortoise. Again, none of that will go. There's a possibility of laser atherectomy, which we tried here, as you can see on the right. Tried a 0.9 laser there, still wouldn't go. And this is when we start to think about potentially using modified rotational atherectomy technique that we'll go over here. So the goal is really, we want to get a wire across the lesion to do atherectomy, but how do we get it across? And you can see here the properties of the rotowire. We've got an 009 part of the wire where the burr is meant to go over it. And then that radio opaque distal segment is 014, and it's meant to have a step up like that so the burr won't go onto the 014 segment so that you can't burr off the end of your wire. But we want to shorten that radio opaque 014 section so that we still keep the safety of it not going in over the end of the wire, but we don't need all that length because we don't know how far we can potentially wire across that lesion, and we just need to get the radio opaque tip just across the lesion so that we can burr, but still have the safety of that 014 segment being on there, even the short part so the burr won't go off the end. So that's where we cut it. So you can see there's on the left side there, the transition to the radio opaque part, which is the 014 part. We cut it with some really sharp scissors, and then we're left with just a few millimeters on the right side there of that radio opaque tip. We then bury our microcatheter as far as we can into that lesion, and then you can see on the left here, free wiring with that rotowire, with that cut wire there. We want to get it just past the lesion. So you can see here, we were able to get a little bit further in this case, but we're not always able to get it this far. Even if you knuckle it past that area, we just have to get it across that lesion so we can burr it. We're then able to take a 1.5 burr and burr it, as you can see on the right. And then after IVUS, able to do appropriately sized vessel preparation and then PCI as you can see on the right side there, with an excellent angiographic result. So 2-week clinical follow-up, he had complete resolution of his chest pain, improvement in his dyspneic exertion, able to wean him off of his anti-anginals. So some of the teaching points are that getting a wire across the lesion, but then not being able to get anything else across is hopefully rare, but certainly depending on the types of lesions that you treat will happen in both CTO PCI and non-CTO PCI. And if you can't get your small balloons, microcatheters, laser catheters across, delivering a shortcut rotowire is an option there. So thank you guys very much. Feel free to email me, robert.riley@thechristhospital.com with any questions, or follow me on Twitter at PERC_surgeon. Thank you guys very much.